All right, welcome everyone. We'll give everyone another minute or two to log in, and then we'll introduce Dr. Smith and have him get started. All right, why don't we go ahead and get started since it's 6:01. So thanks everyone for joining for this week's virtual Global Spine Conference. This week, it's really an honor to introduce my friend, Dr. Brandon Smith. Dr. Smith did his residency at the University of Michigan, actually where he was my intern when I was a chief resident. And he actually had a really outstanding residency career, I would say. So some of the highlights would be, first he had a nerve transfer. He developed a nerve transfer that's now known as the Smith transfer. Maybe we'll learn about that today, maybe not. Second, he was actually invited to be a visiting professor at the University of Pennsylvania as a resident. I'm still waiting for my first invite, 7 years into being a faculty. And so I think that was just really an incredible honor and a testament to really his expertise at peripheral nerve. Dr. Smith then went and did fellowship with Rob Spinner at the Mayo Clinic and just joined our faculty here at Duke, where he's my partner now. So, I thought having Dr. Smith join us today would be really interesting because, as we know in spine surgery, things don't always go perfectly, right? So sometimes people can wake up with, after a straightforward C4-5 ACDF with C5 palsy or iatrogenic lumbar plexus injury or spinal cord injury or what have you. And so today, Dr. Smith is going to talk about situations that can occur during spine surgery and the peripheral nerve techniques that exist to be able to help those patients who have sustained deficits after interventions that we do as spine surgeons. So without further ado, Brandon, thanks so much for joining us. Really looking forward to your talk.
Yeah, thanks, Corey. Thanks for having me. I'm really excited and honored to be here. I'd like, can everyone see this? Cool. All right. So really, I'd like this talk to be interactive if we want it to be. I have a lot of slides, but I think you learn the most if you kind of ask questions and try to figure things out together. So we'll talk a little bit about different nerve surgery techniques, and myself as both a spine surgeon and a peripheral nerve surgeon, I'll surely run into these problems myself and have to think about creative ways to try to fix them. So to start, I have no disclosures. I'll talk a little bit about the plan for the next little bit of the evening. So I'd like to have an interactive discussion, and we can talk about the interplay between spine surgery and nerve surgery. We'll review some very basic but foundational information about nerve injury and about nerve regeneration, things that are important to us in both repair and in the techniques that we use to try to gain back function. We'll discuss some common postoperative deficits or things that happen in spine surgery. If you operate enough, we'll unfortunately run into some of these things. We'll have to find out whether or not there's ways to fix them. So tonight we'll work through a handful of cases to see how maybe a nerve surgeon would be able to help you or help your patient. So the goal for tonight really is not to become a peripheral nerve surgeon like myself, but it's really to try to learn to identify patients that we might be able to help. Patients that have an unfortunate outcome or an expected outcome that just isn't what we want for them. And whether or not we can find ways to really help them live a better life. So the basics, things that give us all palpitations and make us think back to times when we were studying for the USMLEs or different medical school testing. Nerve injury, the basics that we have to understand are kind of labeled here. So when we look at nerve injury, or when we think about nerve injury, one of the biggest things is the question of whether or not you have the ability to regenerate. So will nerves repair on their own? And there's many different grading systems. This is just one of them. This is a 7 classification. But the real question that we always have for both nerve injuries and for nerve repair is there a capacity for regeneration? If there is, you sit and you wait and you try to see whether or not the patient's going to get better. But if there's no chance for repair, then we have to figure out different ways that we can try to help the patients, whether or not we have options for them. The other thing that's interesting or really important about nerve injury is that in many of the different nerve repairs that we're going to talk about, we induce a nerve injury, right? We're going to take a nerve that's functioning and we're going to cut it, and we're going to find a place to hook it into to try to make it give the patient better functional outcomes. But we need to really understand how nerves work and how they regenerate in order to really understand and plan for their recovery. So another anxiety-provoking boards question or medical school question is the idea of Wallerian degeneration. So what happens when you injure an axon, right? If an axon itself is disconnected, the distal portion is going to degrade away, and then the proximal portion has to kind of grow down all the way back to try to reinnervate whatever it was innervating in the first place. It's important to know this more so than just getting a question right on your exams. The reason that we need to know this is because it teaches us that nerves regenerate very slowly. The quoted number we always say is 1 inch a month or 1 millimeter a day. And this is really important for some of the different foundational ideas that we have when we decide how to repair somebody or how to try to get them function back. So denervated muscle, right? If we cut a nerve or we injure a nerve, or during spine surgery, we find some way where our patients have a denervated muscle. It doesn't like that. Muscle loves to be innervated. It loves to have neural connection. And when it doesn't, it starts to get mad. What you see on the left hand of the screen is basic tracings of an EMG. And on the top, you see tracings that we all will just look at the impression or the read on the EMG, but those are signs of an actively denervated muscle with fibs and sharp waves that they comment on in the reports. And then if you look over to the right of the screen, you see muscle atrophy, right? This is one of the things that separates peripheral nerve injuries from most radicular injuries. So when you get a peripheral nerve injury or an injury to a nerve where a muscle becomes fully denervated, you tend to see a lot of atrophy. This is something we see all the time in our peripheral nerve patients, but we don't see it as commonly in our patients who have pure spine injuries. And the reason is that there's a lot of crossover between different levels of the nerve roots. So the muscles don't often get fully denervated the way they do when you cut kind of a distal motor neuron. So why is all of this important, and what does it really matter for us and for our practice patterns as spine surgeons? So the reason this all matters, and the reason that it's important really to understand the background and the basic science behind peripheral nerve injury, is that this is all really a race against time, right? So when you have a patient who has an injury for whatever reason, we are racing against time to try to re-innervate that muscle or give it function back. We want to get the neuron or the axon to go all the way back down to the muscle and to start re-innervating it so it doesn't have irreversible damage. This is just a paper here, a basic science paper that shows every few months that you delay repair, that the muscle has less of a chance of recovery. So this is really important, and where it's mostly important is for referrals, okay? And the reason it's important is because we have kind of an arbitrary cutoff of what we say is 1 year. So we have 1 year approximately to reinnervate a muscle before there's so much irreversible damage that we're not going to have a shot at getting muscular function back. Is it an on-off phenomenon? No one really thinks that, but it's just a general rule that we want to get the muscle re-innervated at approximately 1 year, or at least by 1 year.
And Brandon,
So-
that's, sorry to interrupt. So that would be from time of deficit to time of reinnervation surgery.
Yes, yeah. So time of deficit to time of muscle reinnervation. That's why it's so important. So when you have, so generally we like to operate on these patients at like 6 months. Obviously it changes for every single patient, but what we want is we want the axons to get to the muscle by a year, because a lot of people think that after a year, the likelihood that the neuromuscular junction and that the muscle itself is going to remain in working function is really low. So operating on someone or doing a repair that is 6 inches away from the muscle at 1 year, really you're getting that muscle reinnervated at a year and a half. And that's kind of outside the accepted window, but obviously these things flex a little bit based off of a multitude of different factors, but we really want the muscle reinnervated by a year, like the muscle, not the repair. Does that make sense?
It does. Thank you.
Okay. So what are our reconstruction techniques, right? We're talking about nerve injury. How do you fix this? And what the real question is how do you fix their weakness, or how do you fix their deficit? So there's really 2 methods that nerve surgeons will do, and there's 2 techniques that a nerve surgeon will do, and a few more techniques that our orthopedic or plastic surgery colleagues can do further down the line. But what you can see here is that there's 2 different options. One is you can do nerve grafting, where you cut out a broken part or a injured part of the nerve, and you put in either donor nerve from a sensory neuron or a sensory nerve that's able to be expended, or the other option that's a little bit newer and gaining a lot of traction and becoming a lot more common is to do nerve transfers. And that's where you take a nerve from a different spot and you move it over to give to the muscle that you want to function. This topic in and of itself can take up an entire day at a peripheral nerve conference. So people arguing back and forth, what's better, nerve grafting or nerve repairs? In some cases, you can't do nerve grafts. We'll talk about those. But when you have the option of either graft repairing or completely bypassing the injury and doing a nerve transfer, there is a lot of argument in our little part of neurosurgery and nerve surgery. So again, we could discuss this and debate this for the entire night, but it's a little outside the scope of what we should talk about. So 2 real different reconstruction techniques. Either you cut out the bad part of the nerve and you try to repair it there, or you skip that injury altogether and you try to go closer to the muscle. So the learning point, so if anything to take home, early referrals are key. Again, it's a race against time, and we want to have time as nerve surgeons to really make the best decision and to help optimize the patients for surgery. The reasons that early referrals are super helpful, right, are that as nerve surgeons, what we deal with is patients who have lack of function, and that lack of function is really associated with a whole host of other complications. So we have generally most peripheral nerve surgeons have a team that helps with secondary complication avoidance, things like muscle contractures or muscle tendon contractures, Trojan shoulders. So if a patient has a shoulder weakness, we know to make sure that they're getting range of motion techniques and range of motion therapy to keep them from freezing their shoulder. Because no matter how good our nerve repair is, if the patient gets a contracture or a frozen shoulder, our muscle activation is not going to be good enough to overcome that. And again, with a nerve surgery group, you have specialized therapy. The other thing that's really helpful for us is to decide whether or not to do surgery. We really like to have serial examinations. We like to see the patient and see what their trajectory is. It's harder if we see them at 6 or 7 months and then have a shorter period of time to observe them before we can get them in the really safe, effective window to give them a repair. And then we also have a familiarity with some of the associated procedures. So there are many different orthopedic and plastic surgery techniques to kind of overcome nerve injuries or weakness or contractures even. So it's just helpful to have a team whose main focus is really functional recovery. So now that we kind of have the basic tenets and the basic ideas of how peripheral nerve surgery works and how we like to think about deficits, we'll start to kind of work through a few cases. This won't be encyclopedic by any means. It's just going to show a couple different cases and help us start to think about deficits a little differently. So this is a case that all of us will see as spine surgeons. You have a 60-year-old female presenting with a progressive myelopathy. We decide that she should be treated with a posterior laminectomy and fusion because of her progressive myelopathy. She's doing really well post-operative day 1. She's a little older though, and she's having some trouble with her gait. So we decide we're going to leave her in the house and watch her, help her work with PT while she's recovering. So post-operative day 3, we're called to bedside because she can't move her shoulder anymore. She is no longer able to abduct her shoulder anymore. If there's anyone want to kind of chime in about what this story is, it's something common. If you do enough cervical surgery, unfortunately, we're all going to kind of run into this situation. So a delayed shoulder weakness deficit in a posterior cervical or anterior cervical spine surgery patient.
Yeah, so obviously worried about a deltoid palsy, C5 palsy.
Yeah, for sure. So that's great. So C5 palsies they're common, right? They happen if you do enough posterior cervical surgery, and they're really incredibly frustrating. So this is a meta-analysis, recent meta-analysis where they looked through tons and tons of spine surgeries and found obviously that C5 nerve palsies happen. They happen to all of us. They're incredibly frustrating when they happen, but it's something that's kind of goes with the territory of what we do. So what is it really? So we call it a C5 palsy, but we've all seen patients who have mostly C5, sometimes a little C6. Sometimes it can be bilateral even, I've seen. But most of the time you get a mostly 5-6, often delayed nerve palsy or weakness in the shoulder, sometimes in the biceps. Why does it happen? Tons of papers have been written about this. I think people like to argue a lot about what the etiology of or what the pathophysiology really is of the problem. But yeah,
let's ask Dr. Mamagani, who's one of our co-hosts. It's like midnight in Switzerland, I think, but he's always faithfully joining us. What's your take on? Oh, sorry for my daughter. But Dr. Mamagani, what's your take on the etiology of postoperative C5 palsy?
So hello from Switzerland. Sorry, my camera is really awful. It's some kind of broken. I don't know whether you see me black and white. So etiology, it's really hard for me. I'm reading literature as well. I think it's really something of the most annoying things. I can't give you a better answer. I think it's not dependent on your technique. It's not dependent on your experience. Whether I do it with 10 years more experience than my attendings or not. I think it's some of the most annoying things as well. I can't give you a smarter answer. Sorry.
I think that's really honestly consistent, right? I think everyone has their idea of why it happens, but and most people disagree. But I think we all kind of agree that it's a real annoyance of cervical spine surgery, both anterior and posterior. I feel like you can't really get away from it, and that's what all the meta-analyses talk about. But this talk really is about what can we do about it, or is there anything to do for it after it's happened? So it does happen a lot. 5 to 10% of patients undergoing one of these decompressions experiences this palsy, unfortunately. But 80% of these patients get better, and that's great, right? We're very happy that most of the patients get better. And I think that's what all of us see in clinic, that it's an annoyance for a little while, and after over the course of a few months to a year, right, these patients tend to recover. But 20% of them don't. And it's the 20% that I, as a peripheral nerve surgeon, am really interested in. Is there a way to help these patients? Dr. Belsberg over at Hopkins recently published this paper where they used EMG to kind of predict which patients would get better from C5 palsies, right? So they looked at multitudes of different factors, but they really found that if you didn't have any motor units at 4 or 6 months, that your likelihood of improving was really poor. If you read this paper, it's great because it's incredibly thought-provoking, right? So if you know at 3 or at 4 to 6 months that these patients aren't going to get better, the question is, should we be repairing them? Should we be finding a way to try to re-innervate them? And what Dr. Belsberg's group brings up is, should we try to re-innervate them by nerve transfers? And if we go back and we look at all the different ways that we've learned to treat peripheral nerve patients, does a C5 palsy really look like anything that we do all the time? Is there any, really, does the pattern look like something that we've dealt with for years and have developed kind of an expertise around? And the answer is yes. So although this doesn't look like your typical cervical spine patient, right? This is a little baby who has, can you see my mouse, Coy? Okay, so this is a little baby who has an internal rotation of their shoulder, right? Their shoulder's down, their elbows extended, and their wrist is flexed here. So this is a classic kind of Erb's palsy from a brachial plexus injury. The common pattern of that is upper trunk or C5, C6, or C5. And this is very similar in pattern to what we see in a C5 palsy. And what I mean by that is the deficits are similar. So can the treatments be similar is the question. So when we think about nerve surgery, one of my mentors during my fellowship, Dr. Shin, he always talked about kind of the economy or economics of nerve repair. So his big question, and something that you all should think about and we all should think about, is what do you have and what do you want? So the more things, the more function, the more nerves that you have that work, the more options you have to give to what you want. So in our patients, we always have to look and try to figure out what are the things that we're missing and what are the things that we want to try to donate. So if we look at the brachial plexus, again, another picture that I think it gives all of us anxiety for all the different testing in medical school and afterwards. But what we look at is we see the brachial plexus and we see all of the contributions to the different motor nerves and the different sensory nerves at the upper extremity. The pattern of a C5 palsy is generally C5, right? And you can see that follow all the way out to the muscocutaneous and the axillary nerve. And C6, and these things are what are giving our patients the weakness in their shoulder and the weakness in their bicep. Very similar in pattern to an upper trunk baby who loses C5 and C6 after having shoulder dystocia, right? So now what can we learn from that? What can we learn from the babies that we've treated before? We've done this for a long time, and we've also done this in adults. So the difference with adults and with a C5 palsy and with a brachial plexus injury is that the injury to the kids is often out here somewhere. So you can do graft repairs where you put nerve in between the broken pieces of nerve to try to let them re-innervate their musculature. But in the C5 palsy, we don't really know where the injury is, right? Some of us think it's from the spinal cord shifting back and then the root entry zone or the nerve root entry zone getting stretched. That's why sometimes you'll see patients with extra T2 signal in their spinal cord after this. But we don't know for sure. So using these as a graft repair, you don't have anything to really cut out and repair. So the question is, how can we treat these similar to how we treat babies? So what do you have when you have a C5 palsy? Your radial nerve really usually works, and that goes to your elbow extensors. These patients often don't have elbow extension weakness, right? Your lower trunk stuff like your ulnar and your median nerve, they usually have a great hand afterwards, similar to an upper trunk plexus. They also have extraplexal nerves, right? So they have a spinal accessory, they have intercostals, they have phrenics, so they have tons of donors, right? So now the question is, what do they need? What don't they have? So in order to have a functional arm, you want to be able to get your hand into a usable space. And that's usually up in front of your body and up to your mouth, right? To eat, to use a phone, any way to get your hand up in front of your body where you can use your functional hand. So you need your shoulder, right? You need to be able to flex your shoulder or to abduct your shoulder. You need to be able to externally rotate. And that comes from your infraspinatus, from your suprascapular nerve. And that's so you can get your arm out away from your abdomen as you're trying to flex it with your biceps, right? So these are all the things you need to have a functional arm. And do we have donors? So what we've learned from peds plexus and from adult plexus is that we do have donors, and there are some common ones that we'll use. So the first one we can talk about to get shoulder back is the radial nerve to axillary nerve, or some people call this a Leach-Veng-Bong transfer. But the real thing is that you're taking a little bit of tricep. You usually take one fascicle that goes to the tricep, and you give it to your deltoid. The next thing you can do is take your spinal accessory, and you can give that to your infraspinatus, right, and your supraspinatus, or the suprascapular nerve, and that can help you get a little bit of shoulder and external rotation. So now you can clear your hand away from your abdomen in order for your elbow flexion to work. The common thing we do is we can take your ulnar nerve, a little piece of it, and we can swing it up to your biceps through your musculocutaneous nerve, and you can try to get some elbow flexion back. So if they're missing all of this, and obviously this is different for every C5 palsy that you see. Some of them it's all deltoid, but some do have biceps and external rotation troubles. And if we think about these the way that we think about a plexus, this is a great way to do nerve transfers and nerve reconstructions. One of the advantages here is that the distance that you can do these things from is you can really put the nerve transfer so close to the muscle that it doesn't take as long for recovery as it does when you're doing a graft repair up in the neck. So learning point number 2, something to take home. When you're thinking about a patient with a deficit, you want to think about the economics, right? You want to think, what do you have and what do you want, right? What can you afford to donate to get what you want? The less things you have left over, the less things you can give. So at that point, you want to start really prioritizing what's the most important thing for you. And if you come to a plexus clinic or you watch how we work up plexus patients, some of those patients have such severe injuries that we're really left with very few options, and we have to start doing things like fusing joints to really pick one or two things that we want to try to reinnervate. I think learning point, kind of sub point number 2 is that C5 is an incredibly sensitive nerve. We see this in our decompression surgery. And for those of you that are going to be at the spine section on next week, Tony McCullough is one of the kind of rising stars at Mayo as a resident. He's presenting a paper he wrote with Dr. Spinner about C5 nerve tumors and how they are much more likely to have deficits post-op than any other trunk level schwannomas. So both both kind of intraspinal and extraspinal nerve root tumors. It's a pretty cool paper, and it's it'll be out. I think it's kind of in the proof phase right now, but if you want to hear about that, I think he's talking about it next week. But anyway, C5 is a really sensitive nerve, but we do have options for it. Okay, so we'll kind of shift now. So we've talked a little bit about, yeah, go ahead.
Sorry to interrupt. Quick question about the C5. I think you're going to move on out of C5, it looks like.
Yeah.
Quick question. So it sounds to me like the patient, that it's for a specific C5. I hope I'm understanding this correctly. And that, you know, the patient that maybe has a dense C5 palsy and maybe it gets a lot better over the next 6-9 months to the point where at 9 months or a year, they can get the hand to the top of the head, they can groom. Sure. And there's some, you know, maybe they're 4 out of 5, it's different in their deltoid and biceps. And maybe they say, yeah, the seatbelt's a problem.
Sure.
but most things are pretty close to normal. It sounds like that patient, there's not a thing for, right? I mean, this is, you need to have,
No.
right? This
Yeah.
is a severe palsy that stays severe.
Yeah, you're totally right. So that's a good point. So generally how we think about these is it's really anti-gravity and not anti-gravity, and for that specific joint, really. So if you are a 4 minus, even a 3 on most cases, like if you have full range of motion, almost no nerve surgeon is going to do a transfer. Are they still going to be weak? Yes, but the problem with what we do is we're going to cut the axillary nerve, right? So we're likely going to make them worse than they are if they're recovering. So we're talking about really dense C5 palsies that are not recovering. Patients that with a dead arm wanting to sling it because it's so bad. That kind of thing. So that's a great question.
And Brandon, just for the people who are on, as well as the people who will watch later on YouTube.
Yeah.
So you would say that if someone's post-op C5 palsy does not improve by 6 months, send them to a nerve surgeon?
I'd go even earlier, honestly. I would go. Earlier. So yeah, the Belzberg paper, they EMG'd people at 4 months and were able to predict who really who was going to get better and who wasn't, and they did that with motor unit action potentials. So I would like to see these patients honestly at 3 months. If they're anti-gravity by that time, then you don't have to send them. And a lot of them will be at that point. But if they are still dense at even 3 months, I would like to see them, because then I as a nerve surgeon will get a nice primary exam. I'll know exactly, the language that I'm using for when I'm writing down their exam to see them the next time. A plexus clinic or a nerve, functional nerve clinic, you see the same patients almost on a monthly or by every other month basis to really understand their trajectory, because you want to be able to, with confidence, go in there and cut one of their motor nerves. You want to have a little bit of confidence in a trend before you do that.
Goy, what's your, or any of the hosts or anyone else that's on right now, what are your thoughts on an EMG in somebody that, say, is improving? Are you getting an EMG at some point, and if so, what point?
Brandon, why don't you take that?
Sorry, was that me, Coy?
Yeah.
Yeah. So I do like to see, as a peripheral nerve guy, I honestly get EMGs on almost everybody, and I do it because the EMG itself can give you recovery, give you signs of recovery that are subclinical that you can't really see even on examination. Like the EMGs will often show us, increase in motor units or these different things, or reinnervation signs on the EMG before we even start to see patients have any real recovery. And we see that in our brachial plexus patients a lot. So I think I probably would get more EMGs than the average person, but that's likely my bias. But I think it does give us helpful information.
Yeah, I had a patient who was getting better, not normal, getting better, similar to what I described. And that was one of our conversations is whether we should get an EMG. And the patient kind of said, well, I don't know what it changes. And I said, yeah, I don't know what it changes. Yeah. And I don't actually remember. I think we didn't get it, but it was kind of one of those things where it's I'm not sure what we're going to do with it if we get it in somebody who's improving. Yeah.
I think one of the things that we've seen, or that I've seen before, is the recall is really, it's tough for patients to truly recall and say, oh yeah, I am getting better. But for you, you'll be able to document their exam, and then it'll give you another option or another piece of evidence saying, no, really, look, you're reinnervating so many more muscles. At this point, I know you don't feel better, but we have all this evidence. Your exam last time was better, and now your EMG is getting better too. So that's how we use it in a peripheral nerve clinic, and it does help a conversation that's often a hard one, kind of have a little bit more support, really. Okay, so we'll kind of move on to the next case to talk about, and again, any questions that we want to bring up with. I think it's been really good. So, second case, since it's the summer, these are things that we're all starting to see, or in North Carolina, I think feels like it's been summer for the last couple months. So cervical spinal cord injury, right? If you have a patient come in with a bad cervical spinal cord, you take them in for decompression and stabilization. They get through all their operative stabilization, post-operative stabilization. Now we're getting to kind of recovery and prognosis. So you have this patient that, in this case, can be a C5 or a C6 complete spinal cord injury. And you've done everything now, but it's all time now for them to go to rehab and to try to get better, and to see what we can do to help make them better. And I think there's tons of focus on this in spine surgery, really, as to how can we make the spinal cord injury patients better, whether that's through stimulation and stem cell and all these different things that people keep trying, and we're trying to figure out ways to make spinal cord injury patients better. One of the other things that people are doing are trying to find adaptive ways to make them live their lives better, right? They can come from adaptive prostheses or orthotics, things that can help them with what function they have, try to do more tasks of daily living. And that's also a venue that nerve surgeons are going in. How can we use nerve surgery to help these patients get a little bit better? We're not trying for a home run. We're not trying to make them back to normal, obviously. But what we're trying to do is, are there ways for us to really think about spinal cord injury patients to help them get another level back? As you know, every different level of a spinal cord injury really correlates to a totally different level of quality of life. So always, when we think about our peripheral nerve patients, we say, what do you have and what do you want? So in this case, right, we have a bunch of different nerve transfer options, and a bunch of different nerve and tendon transfer options. And this has been a really growing place in peripheral nerve surgery, especially in the neurosurgery and plastic surgery side. These are names that I'm sure you all recognize as neurosurgery and as spine surgeons, as Dr. Zach Ray and TJ Wilson are kind of the big names in our side. So how do we look at these patients? How are they different really than our brachial plexus patients or our C5 palsies? Well, when you think about these, it's almost upside down in the way of thinking as you are when you're thinking about a plexus injury, right? So a plexus injury happens from top to bottom, right? The nerve roots kind of rip out because the shoulder is getting pushed down, and you lose 5, 6, 7, kind of in a sequential order. That's not always the case, but it's a general trend. But in spinal cord injury, right, you lose function at a level, and then you're left with the stuff above. So instead of transferring things like the Oberlin procedure I told you about, where we took the ulnar nerve and took it to the musculocutaneous, you start to do things where you take nerves from above and swing them down below to give these patients back some functional outcomes. So the paper that I showed you by Zach Ray and TJ had, this isn't coming up very clearly, sorry about that, but they summarized some of the basic things you can do by spinal cord injury level to try to get these patients some helpful things back. So if we took our spinal cord injury patient that we just talked about and called him a C5 level spinal cord injury, what can we do? Well, you can take brachialis and give it to extensor carpi radialis. Why do you want wrist extension? So it seems like a minor win, but because these patients have so little, if you can give them wrist extension, they can use wrist extension and tenodesis to have kind of a rudimentary grip where they can grab and let go. It's just like if you're sitting there right now, you can extend your wrist and see how your fingers flex. This is how the patients can grab modified devices to help feed themselves. Or help grab different devices. So turn them into a C6 now. You can take the axillary nerve and do the exact opposite transfer as the radial to axillary. Instead, you go axillary to radial, and then that way you can get them elbow extension. What does that get you? That gets you help with transfers, which is a huge part of a spinal cord injury patient's lives, if you can extend your arm. Now you switch down to something like a C7, and you can get to these more interesting distal transfers where you're starting to get rudimentary grip back, where you're innervating AIN or innervating PIN with the supinator, the brachialis. These these give you really rudimentary grips, which are different than the grips that you can get when you do things like tendon transfers for grips. The nerve grips are they tend to be much softer and a little bit smoother, whereas the tendon transfer grips that we see are kind of more of an on-off phenomenon when you watch them. Both of those things would obviously have their pros and cons, but it's just a different modality and a different way of thinking to try to get patients with spinal cord injuries one extra level to try to make their lives a little bit better. Okay, so that's spinal cord injury. We'll try another case, and then we'll continue to kind of think through the different issues. So this is a 75-year-old, previous L3 to 5 posterior spinal fusion, has flat back syndrome, and now it's time kind of for a little bit of a big whack, right? She's in bad balance. She needs to be revised, extended. She needs an osteotomy. It's going to be a really long case. But thankfully, she does really well intraoperatively. Blood loss is well controlled. She's doing fine. She goes out to care, and then as she's waking up, she starts to complain, or she's complaining a lot about pain in her 4th and 5th digits. We let her sit for the night with more pain control, and then in the morning we see her on rounds. She's complaining again, still of 4th and 5th digit pain, but when you test her, you notice that her hand grip is really weak. There's something off about her hand. You do further inspection, and then you notice that she has complete loss of function in some of the muscles of her hand. Does anyone have an idea what could have happened in this case? Another common thing that happens in prolonged prone surgery.
We've got Dr. Selby, who's another co-host, who commented ulnar nerve. Dr. Rasuli, one of the hosts as well, says positioning. Positioning ulnar neuropraxia.
Yep, cool, great, perfect. So yeah, this happens, right? I mean, the patients are in a prone position for a long time. It's a known complication. We try to avoid it. Usually, like we do things where we hook up SSEP sometimes to try to make sure we're not getting positioning palsies. That's what we did at Michigan when I trained. But often those were median SSEP, so we wouldn't see the ulnar, and those looked more at the plexus and less at a positioning palsy. But yeah, that's exactly what this is. It's a positioning palsy. And as you can see from this paper in the World Journal of Ortho, there are common complications of prone surgery, one of which just happens to be positioning palsies. Some of the rules, right, are that you don't want less than 90 degrees in your angles at your joints. You want your elbows to be padded, which they're trying to do here. But this is just something that happens. And unfortunately, our theoretical patient has a really bad, severe ulnar neuropathy from positioning palsy. So again, we just go back to our basic thought process, right? We say, what do we have and what do we want, and how can we maybe try to fix this? So we'll always just go back to our picture of the plexus and try to think through it. So we have an ulnar nerve injury, right? But we have all these donors. So now you start to say, oh, are some of these donors, do some of them make more sense than others? Well, the musculocutaneous, right? That all of its motor function stops above the elbow. So that might not be a great donor. Axillary nerve, same thing. Radial nerve, okay, so some of the motor function goes down past the elbow, so this might be an option. But if you think about the function of the ulnar nerve and the radial nerve, they're kind of antagonists to one another. If someone is thinking about activating their radial nerve and you want them to do something ulnar, it really doesn't make sense from a kind of a functional standpoint at the level of the brain. But then we have the median nerve. Okay, so we can kind of think about whether or not the median nerve would be a good donor. But before we do that, we have to think about why this is different than the last two cases. So the last two cases represented potentially upper motor neuron injuries, right? We had injuries. We had injuries that went really, really proximal, but this is actually a focal nerve injury. So we have another option here, right? What is our other option? Graft repair, right? So when a nerve has an injury, if it doesn't work anymore, you can cut out the bad part and put a new part in the middle to let it grow through. So the question is, how well does that work on an ulnar nerve? The outcomes for ulnar nerve grafting it's not great. So it's a difficult nerve to reinnervate because the movements are very fine. It's a mixed nerve, right? At that level, it's both sensory and motor. So it's difficult to know which axons are going to go where. So ulnar nerve at the elbow is difficult to achieve a good outcome. When you need a graft, the outcomes are worse. When you have a long graft, the outcomes are even worse. And proximal injuries, as you could imagine, are worse than distal injuries. This all comes back to the timing thing. It's the more proximal the injury, the longer it takes to reinnervate, so the less likely that you're going to have a good outcome. So what are the other options? We talked about maybe the median nerve, but your question for me should be, if I have an ulnar nerve injury, should I really cut the median nerve? Does that make any sense? That's the last thing I have. That's what's giving me some of my functional hand motion. So then we have to think really about the median nerve itself and what's special about the median nerve. Well, the median nerve breaks into the AIN, right? And the AIN does some long finger and thumb flexors, but it also does a distal pronator, right? The pronator quadratus, which is a very weak pronator of the forearm, and you already have a proximal pronator. So what people have been doing for over 10 years now has been doing something called an AIN to ulnar motor nerve transfer. So what can you do? You can take the AIN at the level of the pronator quadratus, so you don't even lose the proximal stuff, and you can throw it into your ulnar motor nerve. This can give you better outcomes than a graft repair in some people's minds. But again, this is something that would cause a day-long discussion at a peripheral nerve meeting. But it's just an option, and the AIN to ulnar nerve transfer is really elegant. Distal nerve transfer and motor nerve transfer, and it's an option for someone who has a high ulnar nerve injury. Okay,
Hey, Brian,
so that's kind of, yeah.
Great presentation thus far. So before you move on, there's just a couple questions from the chat box. So Dr. Baisa, who's one of our loyal attendees from the Middle East, had a question about case number 2, which is, what is the time interval for nerve transfer in patients with complete cervical spinal cord injury? So those different transfers that you had listed in that table there, is any time fair game for these patients, or X amount of time after their injury?
Yeah, that's a really, really interesting question. So our dogma that I kind of brought up at the beginning, that is for the 1-year rule, right, is for peripheral nerve denervated muscle, right? Because that muscle is going to break down. But with an upper motor neuron injury, which cervical spinal cord is, there is a lot of debate about this as well, because the muscle doesn't totally get denervated. So people are doing these transfers well after a year and saying that they're getting functional outcomes. Most of the time, patients in our spinal cord injury population, we feel like will start to level out at around a year. So I think a lot of these patients will be done a little bit later. But the danger of that is that you have to have great physical therapy, and the reason you have to and occupational therapy. The reason is that once these patients get contractures in their hands, the usefulness of these motor transfers for this rudimentary grip that we're trying to get them, or the wrist extension, if they're stuck in a flexion contracture in their hand, that makes it incredibly hard to get any utility out of the distal nerve transfer without kind of a deconstructive orthopedic procedure with tendon releases and capsulotomies and such. But it's a really interesting question, and I think it's something that hasn't totally been thought out completely or hashed out completely. But I think most people are still trying to do these by the 1-year mark.
Great. And a similar question for case 3 would be, for positional ulnar nerve neuralgias, what's the data on patients who get better versus those who don't? And similarly, how long do you wait before, sending to you?
Yeah. So that's also a good question. I think that is a little bit more of a heterogeneous population. So the real question is, how bad is the injury, right? Do they just have a positioning palsy because they have a little bit of demyelination from the prolonged positioning? Those patients will get better, right? And it goes back to the first picture, the kind of foundational nerve injury picture, the Seddon classification or the Sunderland classification. It all matters about the integrity of the axon, really, and how long and how severe the injury is. So I would want an EMG within at the point of like probably 2 months. And if the patient isn't renervating or showing signs of improvement at that point, then I'd probably want to see them. And the reason I'd want to see them personally is because then I just want to get serial exams. I want to see how they're doing. I want to get another EMG in a couple months and see, are they getting better? Are they getting worse? They usually don't get worse, but they can stall out. And if they're stalled out and they're at a point where it's not functional, and I think that a nerve transfer is better for them, then I have 3 months or 4 months of data saying, then no, this patient's not getting better. It's okay to cut their ulnar nerve, which is a scary thing to do if you're not sure. And if you only see this patient at month 7, then you have a much smaller window to really get to know them, to say, oh no, they are getting worse, or they're not getting worse, or they're not getting better. So I personally would want to see them early so I can watch their trajectory myself. Were there any other questions, Coy?
No, why don't we go on to your last case with our last several minutes left and
Cool.
Bring it home.
Yeah. So last case. So we've mostly focused on the upper extremity, and nerve transfer options in the lower extremity are much more limited, but they're starting to become a topic of interest for a lot of people. So this patient is, we missed, okay, sorry. So 55-year-old with a previous L3 through 5 posterior spinal fusion, has a adjacent segment disease. We decide that it's time to extend their fusion with lateral inner body. So on afternoon rounds, he has some hip flexion weakness, but as with most of the lateral inner body patients, they have some hip flexion weakness because it hurts, right? But on the follow-up exam, or a more detailed exam, we notice that he has really bad quadriceps weakness and a lack of a knee jerk. So then the question now is, what else doesn't work? So importantly, we check and he has thigh adduction strength. He's still good in his thigh adductor. So now the question is, what's going on here?
Dr. Rasuli, what do you think's going on here?
Right. If you did a lateral approach, trans-psoas, probably most likely an apraxic injury to the femoral nerve. It could also be a potentially neurometic injury, but that's very, very rare. It's more likely to be just a retraction-based injury to the plexus inside the psoas muscle.
So yeah, this sounds like a femoral nerve injury, right? We have femoral localizers. We have the loss of quadriceps. We have a lack of a knee jerk, but he has a good adductor, and that's really helpful because it tells us that the obturator still works. And let's see, we'll go. So we'll talk again, I guess, about the anatomy here. And this is a picture from a paper that Dr. Uribe did about the safe zones of lateral inner body fusion work, right? So you can see the femoral nerve here, genital femoral here, and your window is usually in between the two of those. This is ventral and this is dorsal. This is probably an ilioinguinal or another sensory nerve. So trying to get in between here, the real question is likely is a retractor injury, right? Just as you mentioned. You do the retraction, you cause a nerve injury. And again, the retraction doesn't have to cut the nerve and have to be a severe injury. Internally, if it's disrupted enough, there's sometimes a potential that they don't get better. So as you can see here, the obturator nerve is going down, and it shares the same nerve roots as the femoral nerve. So that's why it's important to know whether or not the obturator is involved. Because if the obturator is involved, then you think it's more plexal or even more proximal. And if it's getting worse for any of the trainees out there, you want to make sure you get an exam to make sure there isn't a hematoma. Nerve injuries are almost as a rule maximal at onset. So if you have a patient who's getting worse, like they were a 4, and then an hour later they're a 3, 2 hours later they don't have anything, the patient needs a CAT scan or an MRI to make sure that they don't have a SOS hematoma. But again, same plan. What do you have? What do you want? So when we look at the lumbar plexus, in this case, we have a femoral that is hurt, and let's say this patient doesn't recover. We have obturator that we said works, and we knew that from our physical exam, and that's how we knew he had a femoral nerve injury. So one of the newer nerve transfers, newer by mid 2012. One of the newer options here is to use an obturator branch to reinnervate part of the femoral nerve to get reinnervation to the quadriceps. But again, this is important, and it matters that it's just a focused femoral nerve injury and not a plexal injury. If you get a plexal injury, the likelihood that your obturator is available for a donor is really, really low. So I think that's the last case, and it's kind of, again, it wasn't meant to be a peripheral nerve fellowship in an hour, but it was more meant to be just kind of a, how do we think about things, and what are ways to really to think about these patients to try to help them. So as a wrap up, no one wants to have a persistent deficit after a case, but it's a race against time. So we just need to refer these patients early. You think about what the patient has and what they can afford to donate. And then I think the last thing that's pretty important is that nerve surgery is a field, and it's rapidly progressing. We have new transfers, new techniques. It seems like coming out every few years. So just because there wasn't an option for your last patient, it doesn't mean that there might not be an option for this one. So it's always good to ask somebody. There's great peripheral nerve surgeons kind of all over the country. So there's someone nearby, and probably all over the world even. So there's someone to ask for input, and hopefully we can help our patients because these are things that happen. So again, any more questions? I just really want to say thanks to Koya and the rest of you all for having me, and for everyone for signing in.
Hey, Brandon. First, that was superb. Thanks so much for your time. There actually is a really great question from Dr. Mamagani, Switzerland, which is do you have any sort of age cutoffs for some of these more complex peripheral nerve reconstructions? Obviously in spine surgery, we're always thinking about, how old is too old?
Yeah.
But do you have that sort of same concerns for frailty with these peripheral nerve procedures?
Yeah, it's interesting. So a lot of the nerve transfer patients or nerve transfer techniques are their distal extremities, kind of superficial surgeries. So the morbidity is mostly cutaneous in origin, right? It's when you get worried, it's about issues with infection or issues with wound breakdown. Would I do nerve transfers in a 90-plus-year-old frail person? Probably not. But an 80-year-old spry individual, we start to see outcomes at a year on a lot of these patients. So I don't think it would be out of the question. Younger nerves seem to really do better. I think that's why people like myself really like to do pediatric plexus or pediatric nerve repair, is because the kids just learn how to move better, and you feel good about yourself as a surgeon. But I think as long as the patient seemed healthy enough that they're going to have I don't have a real cutoff, honestly, but I wouldn't do it on someone who is incredibly frail with a couple of years left to live. But I wouldn't hesitate to operate on a 80-year-old who's in good shape. So
Great. And I'll ask one more question to end the night, which has to do with your last case. I think certainly our audience will have a lot of interest in that, especially as the advent popularity of lateral spine surgery arises, and more people have these post-op femoral nerve palsies. But what's been, well, first, what is that technique? You know, are those patients positioned laterally? Do you have like a vascular surgeon who helps you, dig through the psoas? Just talk about that technique a little more. And also, why don't you talk a little bit about the outcomes, and then we'll finish the night.
Yeah, so on a lot of these newer transfers, there's not a ton of data, right? So these are growing and expanding indications. Every time someone publishes a new nerve transfer technique with their case report, they show these like incredible outcomes for their single patient, because that's how you get published. So if you looked up the papers where I got the pictures from, you'd see like incredible outcomes. I think there are probably more humble than that. Our goal really is to try to get people to a functional point. But for the surgical technique, operator to femoral is a prone procedure, generally 2 incisions, and you try all of these. The goal for all of these, or one of the tricks to all of these, is that you really want to do the transfer at the point closest possible to the muscle that you're trying to innervate. So a lot of these are really distal, relatively superficial operations. And the reason is just because of the thing that we talked about earlier. It's like you really want to get this done as quickly as possible. And what I mean by done is you want the nerve innervated as quickly as possible. So you try to put the donor as close to the motor end plate as you possibly can. So it ends up being relatively superficial in the case of a femoral. Finding the obturator is different, it's a little bit deeper, but we operate near the vessels all the time, so we generally do these better.
Great. Well, that was awesome, Brandon. Thanks again for joining us. I certainly learned a lot, and I think everyone did. So Dr. Rasuli is next week's host. He wants to hold off on his announcement until tomorrow. So stay tuned to your social media, and thanks everyone for your time tonight. We'll see you next week.
Thank you.